So Manju, now if you find anybody in the waiting room, are you able to let them in, please?
Okay, sir.
That's very kind. Uh, can I just make an inquiry, Manju? You can see my slides in their full screen and you can hear me.
Yes, sir. I
Yes.
can hear you.
Amazing. Okay. So what we're going to talk about today is the basic principles of ultrasound. And actually, what I am going to start with is just describing what ultrasound waves actually are. So they tend to be waves with a frequency over 20,000. But for every ultrasound machine, what we've got in an ultrasound machine is basically what we call is piezoelectric crystals. And these piezoelectric crystals are organized kind of together so that when they vibrate, they produce ultrasound waves. And really, what causes them to vibrate is electrical current. Now, once they produce ultrasound waves, these ultrasound waves react with tissue, reflect back, and really they're then analyzed by the ultrasound machine to provide an image. And the beauty of it is that without any radiation, you can use an ultrasound machine then to get imaging of the human body and its tissues to be able to give you a lot of medical information, which I would say is hugely beneficial. I think point of care ultrasound now is pretty much the second stethoscope for any physician in the neonatal unit. And I believe that I'd say in the next few years, it will be an absolutely essential part of training. Now, just a few things. When we talk about ultrasound waves per se, we talk about the concept of the piezoelectric effect. And what it basically means is that if you apply electricity to piezoelectric crystals, they will generate sound waves because of the vibration. As I said, that when it interacts with tissue will give you and create an image on the screen, which is what we interpret. Machines at this particular point tend to have a variety of different kind of piezoelectric crystals, but newer machines tend to use new silicon chips. And if you know, Taiwan is one of the countries that really produces silicon chips. So a lot of, I would say, the machines that we use are produced in Asia. So the early machines, which were basically produced by Fujitsu, were actually produced in Japan. And Japan has done a lot of work in basically producing ultrasound machines. What are the components of the ultrasound machine? Well, there's the machine per se, and the machine basically has an image monitor and a screen which you're able to see. But within that big base that you see at the bottom of every ultrasound machine, you really have piezoelectric crystals within a probe. And the ultrasound machine is connected to the probe. Now, once you apply electric current, it causes the crystals to vibrate. Those vibrations basically then interact with brain tissue, reflect back, and give us an image. What is very important is that depending on the frequency and wavelength of that vibration, you are able to alter and get better quality images if you are able to use ultrasound waves well. It's really important that you get a very good idea of why we use particular frequencies for different issues, because really it's not just the frequency of the probe that is important. It's actually how sound waves and their properties interact with tissue that eventually generates the image that you and me get. And really, if you're not using the concepts of the right frequencies with the right probes and altering an image, modifying through image optimization, then your image quality will suffer. And really, that can have a significant impact on how you interpret your ultrasound, especially for the brain. Uh, what is really important at the end of the day is the clinician. And it's quite important that you understand that every clinician interprets images based on clinical correlation. So my
Excuse me, sir. Sorry.
yeah,
Actually, screen is totally white blank, and it is all you have to zoom out. It means it's not showing anything to me. It is totally
okay.
blank.
Give me a moment. That's really
Ji.
I
helpful.
think,
Screen is
but I
okay.
think we are,
Yes.
its screen is okay, I
It's
think.
okay, yeah.
Can you
Okay.
see the images?
We can see, I
Yes,
can
we
Yes,
see.
can
we
see.
can see
Yeah.
the images.
Okay.
I can see too.
What I might do is just share, like I'm sharing the screen again. So these images, can you see a cursor moving on the screen?
Yes, yes, yes.
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 Okay.
Yes.
Excellent. Okay. I apologize, Manju, if there's a slight problem there, but don't worry. The talk is being recorded, so you can see it later on. Now, I think just moving forwards, what I would say is what is important from our perspective is that when we use a probe, we have a gel interface, which basically allows sound waves to penetrate into tissue much more easily. This interface basically acts as a medium through which sound waves can actually penetrate. And I'll explain that if you don't use it, there is a concept of acoustic impedance, where if you have air between a probe and your tissue, you're actually going to have air as a complete reflector of sound waves, which means you won't be able to see anything. And in the lung, this is quite crucial. But even in the brain, using a decent amount of gel and I would say uniform application. So again, if you can just see my cursor over here, it's really important for you to have gel applied uniformly across the probe so that when you hit the fontanelle, you're not having what we call as dropout because of loss of contact, but also because of gel content not being good. Just going further forwards, at the end of the day, what we're hoping to achieve is basically an image on the screen. And this is a classical example of obstetric ultrasound, where we're scanning not just through the mother's abdomen, but fluid and tissue. And that ultrasound basically, with the reflection, is able to bring images of the fetus. That is analyzed by the screen. The reflected pulse detected by the transducer is taken back to the machine, which then interprets those signals and gives us an image on screen, which is what we basically interpret. What does that look like in terms of image generation? So this is just another example that I'd like to show of the probe emitting waves, and we'll talk about all these properties that you can see over here. So you'll find that the probe has reflection where sound waves reflect back. There is then interaction of ultrasound waves with skin, with tissue beneath, with the actual organ. And in that process, sound waves are not just being reflected back, they are being refracted, they are being absorbed, they are basically dissipating and losing energy, which basically is called attenuation. And eventually, an interaction of all these properties, depending on the tissue you are scanning, provides you with an image. And this is a very high quality image of the right ventricle and the left ventricle. But we can alter these properties of sound waves to make our image better. And if we don't do it properly, it can actually make things much worse. Now, that brings me to the most important topic today, and that is really the interaction of frequency and wavelength. So I'd like to make this a little bit interactive. Just uh, what frequencies do we normally use for cranial ultrasound probes? Anybody? Unmute yourself.
8 megahertz with the curved sound, with the curved probe.
Okay, why is that the case, Alberto? Why do we use 8 megahertz? Why not 5? Why not 12?
Because the quality is worse with less frequency.
Okay,
You can go deeper, but you lose quality of the image.
very good, fantastic. So Alberto has hit the nail on the head. So we have a concept which is called frequency. And basically, what is frequency? So I'd like you all to focus on me. So I'm going to clap my hands. So the rate at which I'm clapping my hands at this particular point is frequency. And the duration between each clap is basically called wavelength. So if I clap faster, this is a higher frequency. If I clap slowly, this is a lower frequency. Now, naturally, if I'm clapping slowly, the wavelength between this is longer. The distance between the two claps is longer. And that is the concept of frequency and wavelength. So really, when you use frequency, you generate sound waves at a certain speed, and the distance between each sound wave that's generated by the piezoelectric crystal represents the wavelength. And really, the higher the frequency, the shorter the wavelength. The lower the frequency, the higher the wavelength. And this is a very important concept for tissue. Just having a little bit of a problem here with moving forwards. So yeah, so really, this is an example of crystals, the piezoelectric crystals. And when the electrical impulse is applied, basically what you have is vibration of the crystals. And vibration of the crystals takes place at a certain rate, similar to the way I'm clapping my hands. And that basically is called frequency. But each wave, whenever you clap your hands and you produce sound, it basically causes compression of medium through which the sound travels. That's basically called compression. And then there's relaxation. So really you can see the sound, ultrasound waves being compressed and relaxing in between. And the distance, this is one sound wave, that's another sound wave, this is another sound wave that you can see over here, really represents the wavelength. Each wave moves at a velocity which we call c, and the distance that it moves is called wavelength. But at the end of the day, what we find is that the sound will interact with the brain tissue. And as it interacts with the brain tissue, it will interact with a certain amount of energy, which is called intensity. And depending on the nature of the tissue, some of this sound wave will reflect back, some will get absorbed, some will attenuate because it will interact with tissue much more. And eventually, once it reflects back, it gives you the image that you actually see on your screen. Now, as I've described to you, it's very important that you understand the concept of high frequency short wavelength and low frequency long wavelength. And to explain that, I'm just going to try and see if I can do a little bit of annotation. So let's say this is your brain, okay? And your brain basically at this particular point, and I'm not very good at drawing, but humor me for a moment. Consider me one of the archangels of Michelangelo. I am not, but humor me. So this is the brain. And if you have a probe over here, which is basically emitting sound waves, ultrasound waves at a certain frequency, and this is a high frequency with a short wavelength, then really what is going to happen is you're going to have a lot of sound waves interact with tissue in a very short period of time. Now, when they do that, the distance between sound waves is quite short. And for that reason, these sound waves, they can't penetrate a big distance. And the reason before that is because by the time one sound wave has interacted with tissue, the next sound wave, because the distance is short, is ready to come. So penetration of tissue, when you start using a high frequency probe, is poor. But what it allows us to do is because these sound waves with their energy will interact with the superficial tissue much better, they will give us good resolution. So if you wanted to look at the meninges or you wanted to look at the outer layers of the brain, it would be highly recommended that you use a higher frequency. That would look at the superficial areas of the brain with good resolution. It would allow you to concentrate on those areas. But naturally, if you started wanting to look at the deeper areas of the brain distally, then actually you'll run into trouble. And a very good example, again, if this is the brain and these are the meninges and this is the ventricular space. Now, if you use a high frequency probe, you'll be able to see the superficial areas very nicely, but those deeper areas will not have good resolution, might appear blurred, and not really give you the delineation that's needed to make a clinical diagnosis. On the other hand, if you use a low frequency probe where the wavelength between each sound wave is long, then really a sound wave appearing before the next sound wave appears means that this sound wave will be able to travel a longer distance. Because it travels a longer distance, it will be able to allow you to be able to see deeper tissue much better. The only challenge from our perspective is that as it moves, there will be attenuation again. And this attenuation can affect how we view images. Naturally, from our perspective, if you want to see deeper structures, you want to keep a lower frequency. And in summary, that is the reason why between preterm and term babies, depending on the probe you're using, the probe frequencies that have ideally been described in textbooks vary from 7.5 to 8 hertz. Now, that is an ideal. My recommendation, because you all have different machines and you're all using slightly different kinds of probes. Some of you will have curvilinear convex probes. Some of you will basically have sector probes, which are the cardiac probes. that you play with your frequency to optimize images. And it's not unusual for me when I'm looking at a term baby or an infant who's a few months old, for me to drop the frequency to as low as 5 if I really want to see deeper structures nicely. On the other hand, if it's an extremely preterm baby, and again, we'll review a lot of images today with the ultrasound kind of properties, uh, you might really need a higher frequency to get better images, a frequency of up to 8. And for meninges, actually using a linear probe with a frequency between 12 to 14 actually gives you a very beautiful delineation of dura and pia matter. It gives you a very nice view of the extraaxial space. And in particular, if you want to see a collection in the extraaxial space, any brightness, a linear probe might be better. That being said, we all have limitations. And the idea from my perspective at the end of this course is to give you the ability to be able to use a single probe with the frequencies that are engendered in that probe to be able to obtain images that are good quality, that are reasonable enough for you to make a clinical diagnosis with clinical correlation. That is absolutely key. So, a very important aspect of interpreting any kind of ultrasound image is really, why are you doing the scan? What is wrong with the baby? Have you examined the baby and what your clinical correlation is? Any questions? So, we're 15 minutes into the talk. Any questions? Is the concept of frequency and wavelength crystal clear?
Yes, yes.
Yes, yes.
Yes, yes.
Anybody confused? Please,
Mhm.
I'm not going to move
No.
forwards unless we understand this completely. Any confusion?
No.
Okay, let's rub the blackboard. Now, as I've kind of told you, there is a concept which we call attenuation. And attenuation really depends on frequency and wavelength, as well as the nature of tissue on which you're basically doing the ultrasound. Now, when you use a low frequency ultrasound, as I told you, you will be able to penetrate tissue better and you'll be able to penetrate the deeper tissue better. But naturally, again, just using annotation to give you an example, if this is the brain and its interaction, these are the meninges, this is the ventricles, then from my perspective, low frequency ultrasound will be able to penetrate deeper into the brain. Because it's able to penetrate deeper, it will interact less with the tissue material around it. And because its interaction with the tissue material around it is not so good, you will not get such good resolution. On the other hand, as I explained to you, when you use a high frequency probe, the ultrasound waves tend to be quite close together. The amplitude between them is less. So naturally, you've got just one ultrasound wave interacting with tissue over here, whereas you've got three interacting with tissue over here. So you tend to have better resolution. But naturally, because of the problems of wavelength and the speed with which these sound waves are coming, you will have less penetration. So if you want better resolution, again, what is important is you will have to play with your frequency. Now, the challenge really becomes when you want to see deeper structures better and you're using a low frequency probe where resolution is not so good. And that is where I would say, my friends, there is a compromise to be had. You might have to use a lower frequency and you may not get such good resolution. But in the grand scheme of things, if you are clinically correlating, that should not be an issue. And there is a function which we call focus that I'll talk about, in that you can change focus. You can change how these sound waves are concentrated to basically optimize your resolution of a particular area. And that is basically by changing the focal point, concentrating these sound waves into what is called the near point of the place where you want to get best resolution. And we'll talk about that going ahead. This is just a graphical representation of the difference between use of a low frequency transducer and a high frequency transducer. Naturally, As you use high frequency transducers, your penetration goes down. As you use a low frequency transducer, your penetration increases. The difference, obviously, from our perspective, when you use a low frequency transducer, is that your resolution is poor, whereas when you use a high frequency transducer, like a linear transducer, your resolution is much better. So again, there's a little bit of play to be had. So let's get you interacting. So this is a preterm baby. This baby's 30 weeks intubated, ventilated. Any idea what frequency and what probe you'd like to use? Anybody?
High frequency probe.
So Fuad, so I'll need you to be a little bit louder. What are you going to use? A high frequency probe.
High frequency probe, yeah.
Okay. So what frequency do you want to use?
A frequency of 8.
Okay, you want to use
8
a
and
frequency
above.
of 8.
8
So
to
for a
10.
general scan, I agree with you
8 to
completely.
10.
10, 8 to 10, yeah.
Somebody said 10.
Yes. 8 to 10.
Okay, 8 to 10. So again, it's a good answer. So the beauty of this course is nobody is wrong. There's never a wrong answer when I ask a question. You're all right. And so it may be the case that you're looking at an extremely preterm baby who's 500 grams, and actually the frequency of 8 may not give you such good resolution. So you may have to increase the frequency. In general, rule of thumb is a frequency of 7.5 to 8 really is the best compromise of resolution for basically near term and term babies. But I would say that when you're extremely preterm, you might need a slightly higher frequency. And as you grow older, so if you look at babies, so on the right hand side, we've got an infant who's 6 months. So what kind of a frequency do you want to use over here?
Deeper
Lower
penetrate.
frequency, lower
5.
frequency.
I see.
Okay, so you might, and this is really important. You might start with a frequency of 5. You might, from your perspective, want to kind of go up to 6, depending on how your penetration is. You might have to adjust your focus again, depending on where you want to image. Do you want to see the superficial areas of the brain first? Do you want to see the deeper areas of the brain? There's a whole chapter on assessment of uh, brain imaging, which basically gives you a step-by-step approach of how best to do this. Any questions about this? So we talked about the frequency. What about the nature of the probe? What kind of a probe would you like to use? Would you like to use a convex probe for both babies?
For preterm, it could be a linear probe which has got a higher frequency, and
So
for the 6 months old, probably a curvilinear probe.
okay, so let's just annotate a little bit. You will all thoroughly enjoy my art. It's terrible, but please humor me. So let's say you're using this is the fontanelle. Sorry, don't want to use the rubber, want to use the annotate. So if this is the fontanelle and it's this small, and you have a curvilinear probe, it might be a challenge. So in situations like this, really what you might have to do in these circumstances is basically use a sector probe or a probe that can actually fit in it to give you the images. At the same time, over here, you have a very large fontanelle. And if you start using a sector probe or a linear probe, what is going to happen to your footprint? It's going to be very small and it's really going to cover a very narrow, limited area. So actually a curvilinear probe would be much better over here. So again, I'm just giving you a flavor for the fact that I don't want you to worry. Some of you will not have a curvilinear probe on all your machines. But really, the question from our perspective is what we can then use next. And then it's really working with your probes to be able to optimize your images based on our understanding of physics today. Any questions about this? The standard probe is usually a curvilinear probe. The standard frequency is about 7.5 to 8. Depending on your baby, gestation, weight, size of the fontanelle, you might have to drop frequencies in term or bigger infants to as low as 5. And in extremely preterm babies, you might have to increase the frequencies up to 10. So a linear probe is usually used only when you want to look at the meninges or the extradural space Now, just coming back to sound waves. When we talk about sound waves that are generated, so a simple example going back to this, the assumption that every ultrasound machine makes, and an ultrasound machine has a mind of its own, is that sound travels in one direction only. It also makes the assumption that sound will travel at a certain speed and that it will hit whatever it hits, and that 100% of these waves will come back, and that will come back to the machine, and the machine will basically give you a crystal clear image of what you are going to see. Unfortunately, that is not the case. So, as I said, the machine assumes that sound waves travel straight, that reflection occurs 100% of the time along a straight axis, that reflection is always parallel back to it, that there is no angulation between the sound waves. It also assumes that the amplitude of the sound wave is directly proportional to acoustic impedance, and I'll describe that in great detail. But actually, what we know is that acoustic impedance is a property of tissue, and the acoustic impedance of skin versus bone versus soft tissue versus CSF versus blood varies. And this creates a concept that we call scattering that we'll talk about. The other problem with the ultrasound machine is it assumes that the velocity with which sound waves travel is constant throughout the brain. But that's actually not true. Fluid has molecules that are much closer together. So naturally, sound waves will travel very, very fast through fluid. Similarly, sound waves will reflect off bone, but once they enter bone, because there's a very high density of bone, they will travel very quickly through bone. On the other hand, if you look at air, air is a pure reflector with virtually nothing in between. So actually, it reflects back, and sound wave has a very low velocity through it. So the propagation velocity of these ultrasound waves, whilst assumed by the machine to be constant, is not the case. At the end of the day, we also know that sound waves, as they are generated, are generated as multiple waves. I mean, here we're assuming this is one wave, but these are multiple crystals. So they'll be generating waves over here, they'll be generating waves over here. So you'll have multiple sound waves interacting with this brain tissue. They will reflect off the surface. They will reflect off the surface, and those sound waves will basically reach the machine earlier. But there will also be reflection of the internal structures of the brain, and they will take a longer time to reach the ultrasound machine. The ultrasound machine actually assumes that it sent all the sound waves and they come back at the same time. And for that reason, what we assume is that we'll always get very good images. But actually, what you need to do is play with your machine in order to get images. And that is because of the basic properties of sound. So a sound wave, once it hits tissue, rather than being just reflected back, will also get refracted. Some of its energy will dissipate while it's reflected back, so that that refracted wave has less energy. More importantly, this ultrasound wave will interact with the tissue. And if you assume that skin, meninges, and then you hit brain tissue, what is happening is that it's losing its energy because of absorption from the tissues. So actually, that sound wave is becoming attenuated. So the brightest areas of the brain are usually the skull. There's a lot of reflection back from it, and it's the fontanelle which allows most of the sound waves to penetrate in. And for that reason, we have a very small window where we're going to get the best image quality. So a simple example that I'll give you is this is the fontanelle, this is bone. And really, reflection from bone will be 100%. So if your probe basically is in the wrong place or not incident in the right area, then really you're going to get very poor quality images with a lot of dropout. You really need your probe to be on the fontanelle, closely aligned, without too much pressure, with gel in between to get the best quality images. And can I just say, good quality images tend to be compromised the harder you push. So again, I'm going to show you how I hold the probe, and I'm not saying that that is the way to do it, but a simple example that I'd like to give you with a Sprite can. So have a look at my hand over here. This is the surface of the brain, and this is the probe. And really what I'm doing is I'm controlling the probe with my little finger over here. I am just incident, I'm in contact. And if I have good gel interface with the fontanelle at this particular point, I'm going to get good quality images. On the other hand, if I miss the fontanelle and have bone, and it happens very commonly that babies move, they cry, they're very vigorous. And really, what you want to do then is you press harder in order to try and keep the probe there from slipping. And that is actually the wrong thing to do, because when you press harder, the baby struggles and your probe basically loses its incidence. There is not only less reflection, but there is less interaction of ultrasound waves with tissue because the incident probe is not in the right place. So simple examples of getting good images are explained pretty much by the properties of sound themselves. Sorry, I'm just going to rub this out. Now, sound waves are not just reflected, refracted, and attenuated. They're also absorbed. And a very important aspect of that is the tissue quality and the tissue permeability itself, the tissue property. In that there are certain amounts of tissue that will absorb sound waves much better than others. Now, naturally, if they absorb sound waves much better than others, there's very little sound going to come back from them, very little in terms of ultrasound waves that's going to come back to them and go back to the transducer. And for that reason, those areas will tend to appear much darker. On the other hand, if you have more reflection, less absorption, then those areas will tend to appear much brighter. Sound waves also undergo scattering, and a very good example of scattering is in brain tissue. So we know that the pleura, as you see it in the lung, is one linear shadow. So I'm just giving you an analogy over here of assuming that this is pleura. It's one linear shadow. There's not much in terms of molecules in it. So incident waves tend to hit the pleura and reflect back very, very nicely. And for that reason, what happens is the pleura appears as one bright structure in the lung. But when you look at the brain, it's got sulci, gyri, it's got lots of tissue. And within the tissue, it's got a lot of material. And a lot of material within the brain tissue basically causes sound waves to scatter. And when they scatter, naturally they come back to the transducer at differing times, at differing energy levels. And that basically gives you the pattern that you see within brain tissue or the granularity that you see within brain tissue. Now, naturally, the brain also has ventricular system, which has a lining. So actually, once sound waves hit the ventricular lining, they reflect back better as compared to having penetrated through tissue. And hence, the ventricular lining tends to appear brighter or a little bit hypoechoic. So all of these properties of sound really give us what images we see on the brain, and they're very, very important. What exactly is happening at this particular stage is that the sound waves, the ultrasound waves, are reacting with the brain. They're reacting with the brain in its entirety. Naturally, reflection at the surface through the fontanelle will be better. If you're using a high frequency probe, reflection, superficial areas of the brain will be better visualized. But if you're using a low frequency probe, these sound waves will generate, go in deeper. And for that reason, you'll be able to see deeper structures better. A relative compromise is using a frequency of 7.5 to 8, and that will give you reasonable resolution to be able to look at the anatomy of the whole brain and really get, I would say, good quality images in near term and term babies. For bigger babies, you might have to drop the frequency. For smaller babies, you might have to use a slightly higher frequency. And that is very nicely depicted in this image over here. So really what is happening to the ultrasound wave when it actually interacts with the brain? So as I told you, superficial areas of the brain, which have a lot of tissue, will tend to reflect back. So you will basically, from your perspective, see these areas much better with a high frequency probe. On the other hand, deeper areas of tissue will tend to absorb and attenuate. And for that reason, often the slightly deeper areas of the brain tend to appear slightly darker. And then you have fluid in the ventricular system. And really, that is the system over here through which sound waves basically travel at a constant speed without reflection. Now, if they don't reflect back, fluid will appear dark. But if this fluid has blood in it, as you see with an IVH, lots of blood in it, we talked about scattering. And that scattering phenomenon obviously will increase reflection and cause a bright appearance. So again, just another example of how the properties of sound within brain are basically producing a map over here. And you can see as they interact, and I'm just going to show you this slide again. So you can see at this particular point how the interactions are taking place with, and this is a high frequency probe. So naturally, because of good reflection, the superficial areas are seen much better. But what you're having here is sound waves getting trapped with attenuation. So the deeper structures will be seen less better. Any questions so far? Any doubts, any questions? Is there any confusion here? I will not move forwards if even one of you is not clear about this.
Can you please, for 2 minutes, provide a gist of what was all this once again? Just the gist of low frequency and high frequency with brightness and deeper structure and superficial structures.
Okay, that is going to come now. So, okay. So basically the gist from our perspective when we talk about frequency of waves is this is the probe. Now, if it's emitting high frequency waves which are interacting with the brain, the wavelength between these sound waves is less. So they are basically interacting with tissue in very short distances. And for that reason, their interaction will be with the superficial layers of the brain. Because they interact with the superficial layers of the brain and they're close together, the tissue of the brain will absorb more energy. So, for that reason, you will have better resolution because the tissue is well delineated. But because more energy has been absorbed, the deeper areas of the brain are seen with less resolution. These waves tend to penetrate less. On the other hand, if you use a probe which basically has a higher frequency, the distance or the amplitude between these sound waves is longer. And for that reason, they can penetrate longer without interacting with the tissues as well. The energy dissipation is less. That means that you will be able to see deeper structures better. But because they interact with the tissues less, the resolution is compromised. Eventually, we come to a compromise between the frequency and the probe used. And again, when I talk about the protocol, I'll be able to explain it better to you when we talk about concepts of resolution, why that is the case. But that is the rough gist of frequency and wavelength. We tend to use higher frequencies for more preterm babies. We tend to use lower frequencies for term and near term babies. And really, at the end of the day, we then want to concentrate sound waves and we use the focus to try and optimize our image depending on the depth. Does that make sense?
Yes, thank you.
Now, the
Can I
next
talk for a
important,
moment? Can I talk for a moment? Is it
please,
okay?
please go ahead.
So that means that if we are using a higher frequency probe, then we will the outer layers, the meninges and the structure closer to the meninges will have better resolution. We can identify them better,
That's
but
correct.
the deeper tissues like ventricles and other nucleuses and all that won't be seen much better.
That's correct.
That would be darker. That would be darker, right?
Yeah.
By brighter, you mean to say that they would be
No, so
whitish or so.
that's not correct. So
Okay.
that,
Okay.
so what I would say is that this is resolution that we're talking about. We're not talking about echogenicity. I'll come to echogenicity. Give us some
Okay.
time, and that'll clarify
Okay.
your concepts a little bit
Okay.
better.
Okay.
But the next thing that I want to talk about is acoustic impedance. Now, acoustic impedance basically is a property of tissue. And what it basically means is that whilst the ultrasound machine assumes that sound waves travel in a uniform way with a constant velocity throughout tissue, because of the difference in density between tissues, sound waves tend to get reflected. And that is because of the property of acoustic impedance. It's the tissue density multiplied by propagation velocity. So while sound waves will basically project a sound wave at ultrasound wave at a certain velocity, if it moves through soft tissue, which is naturally from our perspective less dense, it will have a certain velocity. And then when it moves through muscle, it will have a different velocity. And this will be because muscle is denser than soft tissue. Now, the higher the difference in acoustic impedance between two tissues, more the reflection. And this is a very, very important concept. So, a simple example that I'll give you is we know that bone has very high impedance, it's very packed. So, because it's very high incidence, if you put an ultrasound probe over the bone, you'll get reflection. You will not be able to see tissue beyond it. On the other hand, soft tissue has a very low medium impedance is the word that we would use. So naturally, if you start using an ultrasound probe and it passes from soft tissue into bone, there will be higher reflection. And a simple example that I'll give you is that when you put and do a lung ultrasound, you put the ultrasound probe over the ribs have soft tissue on top of it. And the soft tissue ultrasound velocity through the soft tissue is higher, but the velocity through bone at this particular point, because of reflection, it's high in bone, but the high impedance will cause reflection. And hence, really, that is why the pleura appears bright, the ribs tend to appear bright. In the brain, really, the applicability of this concept is that when you put the probe over an area where there's a small fontanelle, you are going to have bone interfering because of its high impedance with reflection and causing more reflection of sound waves. So really the placement of your probe in the fontanelle in that area is quite crucial to you getting good images. Similarly, from your perspective, air has very low impedance. And this is a concept that people get very confused with. But actually, if you have soft tissue over air, what is going to happen is you're going to get a lot of reflection, even though the impedance is low, because there's a difference between the impedance of soft tissue and air. And a classical example that I'll give you is a pneumothorax. So if you have air between the pleural layers, what happens is you have soft tissue with the visceral pleura underneath, parietal pleura on the top. And basically all you get is reflection of all of the parietal pleura back with reverberation artifact, and that is because of the difference in acoustic impedance. So the impedance of the tissue itself is not the cause for reflection. It's the difference in impedance between different tissues that causes reflection. And that is quite crucial. So the meninges will give you very good reflection. On the other hand, as you go into tissue and the interface between the meninges and tissue, again, there's a change in acoustic impedance there. So the superficial layers of the brain, if you're using a high frequency probe, will look very nice because there's a lot of reflection. The deeper areas will look less nice. When you come to the ventricular system, actually that's fluid. And we know that fluid, basically, from your perspective, again, there's a slight difference in impedance between the ventricular lining. So if you look at my hand, the ventricular lining and fluid. So the ventricular lining has a higher acoustic impedance as compared to fluid, and hence the change causes more reflection. So the ventricular lining is seen very well, but fluid itself, CSF, actually will have a constant impedance, no reflection, and that is why it appears dark or hypoechoic. So this is why acoustic impedance is very important. It's not something that you really can change a lot. It is because of the property of tissues, but you can, from your perspective, alter frequency, focus to basically try and optimize your images. As I've said, when you look at the actual acoustic impedance of individual tissue, bone has very high acoustic impedance. When you look at fat, it's quite low. So again, sound waves will tend to travel much faster through fat. They will tend to be reflected much more from bone. But actually, if you have fat over muscle, then really reflection will also be very high because of the difference between acoustic impedance. So there's a difference. Muscle is 1.73, fat is about 1.65. They're similar, but slightly different. So the difference in reflection will help you delineate those layers. And again, with lung, this is quite an important concept. So how does this apply basically to cranial ultrasound? So we know that cranial ultrasound has multiple tissue interfaces. We've basically got skin, that is the skin layer of the fontanelle. You then basically have fascia. You then have the dura mater. You then have the pia mater. You've got some fluid in between both of them. You have what I would say is the extraaxial space between them. Beneath that, you then start getting sulcal gyral appearances of brain tissue. And then you really get tissue proper. So that tissue, basically, from your perspective, will be a good reflector. And that's why sulcal gyral appearance gives you good reflection and helps you delineate really what the maturity of the system is. And then you have the ventricular system, again, the margins of which will be good reflectors because of the difference in acoustic impedance. But the fluid-filled areas of the brain, naturally, it's all fluid. The propagation velocity will be the same. There'll be no difference in acoustic impedance here and here. So actually, these sound waves will go through. They will reflect off the distal area or the lower area of the ventricular system that you see when you do the sagittal views. So you'll be able to get good images of those systems. But the fluid itself, the CSF, that will appear dark unless there's blood in it. Okay? Any doubts? Any confusion about this? Are you absolutely crystal clear about this? I will not spare you in the next lecture if you cannot answer the questions. I will put you on the spot. Again, just the concept that using gel helps to reduce the acoustic impedance between skin, the transducer, and the tissue underneath. So it basically allows sound waves to penetrate through the fontanelle so that it can interact well with brain tissue. If you don't use it and there's just air between your probe and the the fontanelle, you're not going to get any images. But what is very important is also the fact that some babies have a lot of hair. Now, it's just a simple thing. But really, if I am doing a term baby or an infant with a lot of hair, what I like to do is try to part it, try to make a partition to be able to get as little hair interfering with my fontanelle as possible. And you can see how hair in this particular situation can really be problematic, especially if you have hair like my son, very similar to he tends to have a UK haircut these days, which I'm quite disappointed about, but the hair is completely standing up. There's no way I'd be able to get an ultrasound probe on his head. Okay, so we'll just move ahead. Please don't tell him I said that. So once sound waves penetrate, again, they interact. Now, this interaction, as I've already said, meninges, brain tissue, CSF spaces. And based on the sound waves and the way they interact, you'll see superficial tissue that's bright. You'll see the ventricular system and fluid that actually appears dark. Now, there are two other concepts that are important before we move forwards. And one of them is basically called specular reflection, and the other is called diffuse reflection. Specular reflection is a simple concept. So if you're scanning a flat surface, so any examples of a flat surface in the body that you scan? Anna, can you tell me, can you talk about a flat surface that shows specular reflection?
Thorax? Liver, maybe. Liver?
Actually, liver will show diffuse reflection because it's got tissue.
Pleura.
Pleura,
Lung.
beautiful. So pleura is just one layer. Simple, one simple layer. So pleura basically tends to show specular reflection. So sound waves will basically reflect back. You'll have very good reflection. Pleura appears bright. What about the brain? Will the brain have specular reflection or diffuse reflection?
Diffuse reflection.
Diffuse
Absolutely.
reflection.
Because of the sulcal gyral appearance
Diffuse.
being irregular, you tend to have diffuse reflection. And because you have diffuse reflection, that is what gives you the anatomy, the sulcal gyral appearance of the brain and the deeper areas. I'm going to skip this, but this is just an example of what we've discussed. The echoes produced on the brain are quite scattered, hence they define anatomy much better. Whereas on the pleura, really you have virtually, I'd say, 80% of the waves reflected. So you don't actually identify tissue in the lung. What you identify is artifact. Very similar kind of concept. Now, what is very important from our perspective is this concept of angle of inclination. So when you're doing Dopplers in particular, it's really important that your probe has a very small angle between the blood vessel and the incident wave. Because if your wave reflecting back is perpendicular, what is going to happen is, let's say this is a blood vessel. These are blood vessels that you're doing Dopplers on, and they have blood cells. And those blood cells are moving in a particular direction. So actually, if the incident sound waves hits those blood cells and comes back at a much lower angle, the intensity and energy of that sound wave will be higher. Because its velocity and energy will be more accurately calculated, you'll get a more accurate reflection of velocities. And this is a very important concept when you're trying to do anterior cerebral artery or middle cerebral artery Dopplers. So if your probe is not incident to or in the direction of flow, and you have a high angle of inclination as you see here, the sound wave will not reflect back with as much intensity, energy, and velocity, and you'll actually make an inaccurate estimation. And that's very important when you're trying to do resistivity index. We've already discussed this. I'm going to skip propagation velocity. Eventually, the gist of what we've discussed over the last 50 minutes really is the concept that you use ideally a curvilinear probe, which gives you the ability to be able to send sound waves into the brain to be able to give you maximum tissue exposure through the fontanelle. That interaction with the brain tissue helps to delineate very nicely, depending on the frequency you use, the meninges, the interhemispheric kind of areas, the extraaxial space, then the superficial brain tissue, the sulcal gyral appearance, gives a bright appearance to the corpus callosum. Naturally, it's tissue-based. There's a difference in acoustic impedance here and here. But then when you come to the fluid-filled ventricular system, the margins are well seen, but actually the inner area is quite dark. And because the inner area has a constant propagation velocity and there's no difference in acoustic impedance, it tends to appear anechoic. So CSF tends to appear anechoic as you move down. The cerebellum has got tissue which is bunched up and is in a very narrow, very dense area. So again, a lot of tissue here that shows a lot of reflectivity. But again, just a question for everybody. So what will you see better if you are using a frequency of 7.5? Which structures will you see best in this tissue? So Dr. Hayam, can you hear me?
Yes, I can hear you, doctor.
Okay,
The
Dr.
higher
Hayam.
the frequency, the less the penetration. So I will see the closer structures.
So
So
you'll see
meninges
these areas nicely. What about the
Yeah.
cerebellum?
No, it will not be visualized clearly because penetration is less.
So what can I do to make things better?
Decrease.
Decrease the frequency.
Okay, but the problem with that is what will happen to my resolution?
It will be worse.
So how do we manage this situation? Use the mastoid window. If you use the mastoid window, and that's why the mastoid window is very important, your probe will basically be over here. It'll be closer to the cerebellum, and you will not have that problem. And hence the need for use of axial windows. Okay?
Thank you.
Any questions? So these are just examples, again, of our interaction. This is what the brain basically looks like. And as I mentioned to you, this is the fontanelle. This is the incident probe. You can see the lining over here. I mean, this technically would be one meningeal layer, extraaxial space. I'm just going to use my... I wonder what's happened to the marker. There used to be a marker on it, but... So just, these are the extraaxial spaces. This is kind of the pile layer. You can see, again, there's going to be attenuation of sound. So naturally, because there's attenuation of sound waves, these areas appear darker. But the lining itself, there's a difference between acoustic impedance of the pia and the tissue underneath. So the pia actually appears quite bright. And as soon as you come to the ventricular system, again, slight brightness, there's attenuation, so less bright than the pia because sound waves have attenuated by the time they've reached here. But you can see the margins here. But the CSF inside it has got a constant kind of acoustic impedance, so that appears dark. And then you kind of see the back of the brain, and this is really the cerebellum, very packed with tissue, lots of molecules. So there'll be a lot of scattering, a lot of reflection from this area. So again, it appears bright. So I just hope that this field of ultrasound physics kind of gives you a little bit of an idea of how we have kind of moved through that and why we get this image appearance. As you can see that when you have hydrocephalus in this particular situation, there's a huge amount of CSF, which looks anechoic, again, because there's no difference in the acoustic impedance and the propagation velocity of sound waves in this area will actually be the same. On the other hand, reflection from the ventricular lining, because of difference between the acoustic impedance, will be higher, so that looks bright. And then at the back, again, you've got ventricular lining. So sound waves that are traveling with a constant propagation velocity suddenly encounter tissue which has a higher acoustic impedance. The difference in acoustic impedance is going to cause more reflection. So then you can see the back. And then if you have blood, as I said, scattering phenomenon, you can see what is basically a hypoechoic area, which is basically a clot that you can see over here. Again, because of the phenomenon of reflection and scattering. So even though sound waves are attenuated, so they're attenuated over here, once they reach this margin, fluid basically allows sound waves to travel with a higher propagation velocity. So they become much faster over here. And when they're faster in that particular situation, there's less attenuation. They bounce off the RBCs, and that gives you the bright appearance that you see. I've covered all of this. We've covered attenuation. And
Doctor, would you please just tell me again? I didn't get this attenuation. What does it mean exactly?
Okay. So basically what attenuation means is that as sound waves go through tissue, they interact with the tissue. Now, naturally, sound waves have energy, but if they interact with tissue, they're going to lose that energy. But we have dense tissue over here, and over here you have fluid, which basically, from our perspective, is not going to cause the energy to dissipate that much. So this phenomenon of the ultrasound probe sending sound waves through tissue and the energy that is absorbed by the tissue causes the sound waves to become attenuated or weaker. And then when they're weaker, they'll reflect back less, and that will give you images that are darker. If they go through fluid, there's even less reflection, but there's less attenuation. So they hit bright areas over here with a higher velocity, and that gives you brightness. It's a slightly abstract concept, and my advice would be that you have a very nice read of the chapter on the portal because that explains it and explains it with graphics. And the other strong portal that I would recommend that you read if you want more detail is basically POCUS 101. It's beautiful. It's absolutely beautiful. I will also send you some articles so that we can clarify this a little bit better.
Thank you,
So
Doctor.
basically, attenuation is absorption of the sound waves. The energy becomes less, and hence reflection will be less, and that tissue will naturally appear less bright. Again, we have an attenuation coefficient It's a little bit difficult for me to cover all of this in this particular session, but a good example that, again, I'd like to give you is a baby who's got a grade 4 IVH. So if you're using a probe with a certain frequency and there's no IVH, sound waves will basically penetrate through the fontanelle. They'll interact with the tissue. Naturally, because they interact with the dura and the pia first, there's a lot of reflection, gives you a bright image, and then they become a little bit attenuated, so you get a slightly darker image. But the sulcal gyral appearance, there's a lot of scattering. Because of scattering, you tend to get the sulcal gyral appearance. Now, if you have an IVH, you have a lot of blood, and this blood basically will cause a lot of scattering. But more importantly, what we also know is that blood has a uniform density. So not only will sound waves scatter, you'll get the bright reflection that you can see. These sound waves will travel with a uniform intensity through. So actually what you then see is one large bright area because of the uniform nature and propagation velocity of the sound waves, which then reflect back off the distal margin. Again, the reflection gives you a bright appearance, and that's why an IVH appears bright. If you do not, and as I said, keep your probe in the right place, you are not going to get good quality images. But more importantly, your angle of inclination will suffer, and you will get a wrong velocity. You will calculate your RIs incorrectly. This can be quite significant if you want to do prognostic evaluation of a baby with HIE. Basically, in summary, putting all of this together, I would say that eventually sound waves interact in all of these kind of ways to give you an image. And a really good way of looking at it is looking at the heart. So this is a scan sector, and we're using a sector probe with the heart. Sound waves are traveling. They reflect back off the wall of the left ventricle, which is quite thick. But then we have uniform density, so uniform propagation velocity, no reflection, and attenuation while they interact with the myocardium, which appears hypodense. And then you have blood again. And it's quite interesting, the analogy over here. The acoustic impedance between the inner layer and blood is not so much. So actually reflection of this is not as good as reflection of the myocardium. Hence it appears less bright. But actually there is going to be no reflection of the ventricular cavity. So blood in the ventricular cavity, when we look at it, actually appears dark as opposed to appearing bright as you would see in the ventricular system. And that is because there is a difference between the acoustic impedance of CSF and RBCs. There's no CSF here. This is all blood. It's one medium. Hence, it appears hypoechoic when you see it in the ventricular cavity. Okay? Any questions? Any questions, guys?
No.
Okay.
Need to read it a little bit
Yeah.
more to have
I
questions.
always, after this session, we kind of tend to fry your brains. And because we tend to fry your brains, it's quite an abstract concept. So I'm not going to cover the advanced principles today because tomorrow what we're going to do is we're basically going to go through the different views, the anatomy, and how we take those views. And once we've done that, on Sunday, Sunday will be a slightly longer session where I will cover a little bit of the advanced anatomy and the protocol. But for me, what is very important is that you have a very good understanding of the concepts of frequency, a very good understanding of the concept of wavelength, why we use high frequency probes and low frequency probes in certain situations, and then again, the concept of acoustic impedance. If there is a difference in acoustic impedance between two tissues, reflection will be much higher. The actual acoustic impedance of the tissue itself does not cause reflection. It is the difference in acoustic impedance between the two tissues. The closer the acoustic impedance between two tissues, the less the reflection will be. So if you have skin and muscle, the acoustic impedance is very similar. So actually there's not much reflection. So what you don't see is brightness. But as soon as you see pleura underneath, it becomes bright. Again, skin and dura, there's not much difference in acoustic impedance. So they nearly look like one layer. But when you look at that extra-axial space with pia underneath, the pia basically has separate acoustic impedance and there's fluid there. And that difference in acoustic impedance between the interhemispheric fissure and the pia basically has high acoustic impedance, which will cause more reflection, and hence the pia appears bright. Once you penetrate the pia, you have tissue. Again, the superficial area appears bright, but then tissue itself is uniform. The propagation velocity in tissue is uniform in the brain, and there is less reflection, but there's also absorption of those ultrasound waves by the brain tissue, which gives you that slightly dark hypoechoic appearance, except where you have sulcation and gyration, because there will be scattering and reflection in those areas. So it's just how sound waves interact. Once they hit the ventricular lining, that appears bright. But again, CSF will have a constant propagation velocity. Acoustic impedance will be highest at the ventricular lining in the CSF margin. But once sound waves are going through CSF, they will not reflect back. They will have a constant propagation velocity. And because of that lack of reflection, it appears anechoic. Once it hits the distal margin, it will reflect back and appear hyperechoic. And when I talk about the protocol, I will basically show you all the views and will give you a good understanding why the different structures of the brain look differently, why blood looks bright, why a parenchymal hemorrhage will look bright, why from our perspective, if you have a large cyst of the brain which has fluid in it, it will appear like bright margins, but the actual fluid within will give you an anechoic appearance or a cyst-like sign. So floor is open to questions. Any questions?